the WFNS recommendations on back pain. And now it's my honor to invite Dr. Corinna Zygourakis to present about new tools in spine surgery, machine vision versus CT-guided navigation. Thank you.
Wonderful. Thank you so much, Vanessa, for the invitation, and thank you to Salman and Mehmet and the WFNS team for the invitation to speak today. Can you all see my slides?
Yes, we can.
Okay, wonderful. So my name is Corinna Zygourakis, and I'm an associate professor at Stanford. These are my disclosures, which are relevant to one of the navigation technologies that I'll be speaking about today. Okay, so first of all, why should we use navigation and image guidance? So I would argue that in order to place our screws in the spine, we need the highest accuracy and high precision, because even in the absolute best and most experienced hands, bad things can happen, okay? And when we look at meta-analyses looking at conventional freehand screws, moving to fluoroscopy-guided screws, and then 3D navigated screws, we see a significant increase in the accuracy of these screw placements, okay? In our own meta-analysis of over 50,000 screws, we found by far that CT navigation had the highest accuracy. And so I would argue that the freehand technique is like using a compass. Now we all have access to smartphones with GPS on our phones. Why would we not be using these in order to place screws with the highest accuracy when the stakes are so high for our patients? So I'll talk first about a stealth navigated guided MIS fusion technique, which can be a wonderful tool for us. Here's a patient who presented through the emergency department, 77-year-old with some medical comorbidities, including heart disease and COPD. He had a history of prostate cancer and a known rising PSA, but no known metastases. He came in with 5 days of lower back pain, progressive lower extremity weakness, and now unable to walk for the last 36 hours. Full strength in his upper extremities with some pretty profound weakness in his bilateral lower extremities, and you can see the exact distribution here. His MRI with and without contrast showed that he had some significant disease, both osseous metastases as well as epidural disease that you can see here in the lower thoracic spine. And so I would argue that this is actually a great case in a patient who is likely going to be undergoing postoperative chemotherapy and radiation to consider a minimally invasive approach. So we actually took him to the operating room for a T4 to 12 minimally invasive fusion with mini open laminectomies to get this epidural disease here. So here are the steps and some tips and tricks for stealth navigation. So you position your patient on a radiolucent Jackson frame. I open the skin with a midline incision, and then I use the C-arm to approximate the level. I'll open the midline to expose the spinous process superior and inferior to the levels of interest. So in this particular case, it's a big construct from T4 to T12. So I'm going to be placing 2 separate spinous process clamps, one at the very top and one at the very bottom. These are what some of the spinous process clamps that look like. Then we bring in our O-arm and we perform an O-arm spin. And then I'll use a navigated probe to plan stab fascial incisions for each of the levels of the pedicle. Use the bovie to get down to bone, and then use a navigated power drill to drill the screw trajectory. I place a K-wire through the trajectory, and there are many systems that now offer K-wireless MIS screw placement. However, I still like using the K-wire because it allows me to also get that tactile feedback, just like you would get with a ball tip feeler if you're doing an open screw and you can feel all of the sides of your pedicle. Use a navigated cannulated tap over this K-wire, and then I place a navigated cannulated screw over the K-wire using the navigation. And then I will also get an intraoperative O-arm spin afterwards to confirm good screw placement because you do have the tactile feel from the K-wire, but you don't have as many ways intraoperatively with MIS fusion techniques to ensure that your navigation is off. If it feels off, it probably is. So that's an important time for you to consider whether or not you need to re-register. After placing the screws in this case, perform a mini open decompression if needed. Place the rods with an MIS rod inserter. So this is really important, especially for very long constructs. You have to make sure that you have sufficient rod at both the superior aspect where you have the inserter, you always have enough rod. But at the bottom, you need to make sure you have enough rod for these big MIS constructs. So usually it'll be helpful to get an AP X-ray in order to do this and confirm that you have rod at the very bottom as well before removing your MIS rod inserter. Then, so this is actually the instrumentation portion of the procedure. And to do a fusion, we use a navigated Midas burr and then decorticate the facet joints and put in your bone graft of choice. So such as, for example, demineralized bone matrix that I'll inject. Stealth MIS cases can also be great, for example, so in trauma. So here's a patient with a 3-column fracture, and this is a really nice case where you don't need to do any decompression. So this can be done very nicely and efficiently with this MIS technique, and also a chance fracture here shown on the right. So stealth navigation, pearls and pitfalls, okay? So it can be ideal for trauma without significant compression. Ooh, and I see the countdown timer up there. Okay. So I need to go quickly. Great for hybrid mini open separation tumor surgeries, degenerative disease with primarily foraminal stenosis that we address via inner bodies. I mentioned using 2 clamps and 2 stealth stations for longer constructs like the case I showed. Optimizing clamp placement is very important. You want to be as close as possible to the region of interest, especially if you're in a mobile area of the spine, because your navigation accuracy decreases the further you are away from the clamp. It's really important for you, your resident and fellow who's operating with you, to not touch the clamp. And it's really important also to keep in mind that navigation can be off if you manipulate or retract soft tissue too much, okay? And so you need to be constantly rechecking your navigation, even in an MIS case. And there is a limit to the size of patients, even with MIS. We say it can be great for larger patients, but here's an example of a patient where all of the balls that were attached to the instrumentation to do the navigation were deep within the patient and getting bloody every single time I put them in and out of the patient. So you need to keep that in mind too in terms of what you can do depending on your patient population. Okay, 7D nav can also be a great tool. So this is machine vision technology, so different from you get a preoperative CT scan. I use this in a case of a patient who had this obviously very unstable T10 fracture. And so how does machine navigation vision work? Well, similar to the technology that you have in your Tesla self-driving car, there are actually cameras that are in the surgical light that's shown right here that's above the field. So in terms of your workflow for the 7D, you'll position the patient, you'll use your C-arm to approximate the level, and you have to perform an open exposure down to lamina and TPs with meticulous soft tissue exposure. You place your spinous process clamp near your region of interest. You have similar spinous process clamps as you do with other technologies. You bring the 7D machine over the field, remove other lights, and get a really quick flash registration that takes a few seconds. You'll select your points on the patient anatomy that align with the patient's that align with your plan. And then you've gotten a preoperative CT scan for this patient, so you don't have to bring the O-arm into the operating room. You confirm the accuracy of the registration. So this particular one is showing you all these green points that co-localize your current image to the preoperative CT scan, and that is a very good looking registration. You'll use a navigated probe to determine your screw entry point, and here you see something that's very similar to what you would see with your other systems. You can use a navigated power drill to drill your screw trajectory, a tap, and then this is a virtual K-wire because this system is actually agnostic of screw type, so you can use any brand of system. So you have a virtual K-wire that you're using now to place your screws. You can do this even in patients that have had prior hardware. So here's an example of a patient where I was able to register off of old hardware that the patient had. And I used this, and it was a nice way. I did both a fusion and then was able to see where I was when taking care of this very calcified thoracic disc. You can also do a preoperative CTA, so you can see the vertebral artery. So this is an example of using that in a posterior C1-2 fusion, and you can see the course of the vertebral arteries relative to our plan, which is another fun thing that you can do with 7D navigation. Okay, it's ideal for open cases where large open decompressions are needed. It can be used nicely for unstable spine fractures. I'm running out of time, so I'm happy to take any questions, but this requires meticulous bony exposure with soft tissue removal and suctioning of any blood in the field, really paying attention to lighting and shadows during the flash. You have to optimize your point picking, and I could do a whole 10 minutes just talking about that, and we talk about it in the OR every day. It doesn't work as well for like 1 or 2 level lumbar fusions because of how much shadowing there is for your registration. And it's also important to keep in mind that it's a different line of sight. The camera is directly over the field. So when you lean in to see something, you or your assistant can inadvertently block that. So that's very important. Um, We'll go really quickly here, but basically 7D can have improved workflow. You don't have to get an intraoperative O-arm spin. It's really easy to get a repeat flash registration if you move the clamp. It just takes a couple of seconds to do that. You don't have to get another spin. And so this allows for some decreased and also decreased intraop radiation exposure for the surgeon is really important and the entire surgical team, just like you have with some of the other technologies. But it doesn't currently work for MIS, and you really need to have great bony exposure. So in conclusion, I believe that navigation is becoming the gold standard. Different navigation platforms have specific advantages and disadvantages. Machine vision image guidance can improve intraoperative workflow and decrease radiation exposure in the majority of open posterior spinal fusions. But CT-guided navigation, at least for me, still remains the preferred MIS workflow, and these are